Beginning, and I need to swap.
Oh, we can see your notes again. Just see, there we go.
They're gone?
Yep, they're gone.
Oh, okay, wonderful. So hi, everybody. Welcome back to those that we know, and welcome for the first time to those of you who we do not know. I'm Lindsay Wetterstrand. I work at Royal Inland Hospital here in Kamloops, so wine country. Hi, everybody. And I play a few roles here. I'm a registered respiratory therapist. I teach up at the Thomson Rivers University in the Respiratory Therapy program, and then I'm in transition right now, but I'm the site instructor for clinical respiratory therapists, and I'm the department educator, kind of sharing that role with Alexa.
Yeah, and my name's Alexa McMillan. I also work at Royal Inland Hospital alongside with.
I can hardly hear you.
The audio is not great.
And I can't
You're
see
fading out
Are we better now?
a little.
Slightly, not enough. Your chart is really good.
your face.
Lindsay, yours was okay, but Alexa, your voice is not projecting.
All right. Well, I'll talk
Lindsay's
louder.
completely faded at the end,
It's because I'm loud, and somebody tells me that all the time.
but you faded right out at the end.
Okay.
So my name's Alexa McMillan. I also work at Royal Inland Hospital here with Lindsay. I am the assistant professional practice lead for the Respiratory Therapy Department. And then right now, Lindsay and I are sharing a position as the educator until she fully transitions into it next week. I also volunteer for the BC Society of Respiratory Therapists, so helping with advocating for our profession.
Yeah. So how's the volume? Is it all right for everyone?
Yes.
It got better. Wonderful.
Better
Okay.
But I
So
can't, excuse me, I can't see your faces. I can only see that blue board with the words on it.
oh yeah, because we're sharing the presentation. So can you see the
Oh, I'm
presentation?
sorry.
That's okay.
I
Yep.
see it, yeah. I
First
thought-
time for everybody. It's more than okay.
I
So
apologize.
so good. So the topic today that we're going to be discussing is understanding your COPD and asthma. Today's presentation is a lot of foundational information, so it might not be as interactive as we're hoping the other ones will be, but it's really important for us to provide that foundational knowledge to the group so that every sequential or subsequent presentation we do can build off of that. So today we're setting the foundation to build the house. Okay. Oops, here we go. So like I said, today's webinar, we'll be discussing that topic. This is the first of 12 webinars that we, in conjunction with BC Lung, are developing for this patient population. Just a quick little tidbit, 1 in 5 British Columbians have a breathing issue, whether it's a lung condition or a breathing issue. And the most common ones are COPD and asthma. So it's important that we give you the information that you can then live your best life with. Okay.
Awesome. So today we're going to talk a little bit about the anatomy of your respiratory system. So we'll go through some of the structures. Then we're going to talk about the function. So we'll dive into ventilation, how gas exchange occurs. And then we're going to talk a little bit about understanding COPD and asthma. So kind of defining them, different causes, talk a little bit about tobacco smoke, and then we'll go into some signs and symptoms and then wrap it up at the end. So to start off, our respiratory system is a complex system, and it has many components. It starts with our nose, our mouth. It leads deep down into our respiratory muscles within our lungs, and those lungs within there's different airways that branch off to teeny tiny little sacs at the end, the alveoli. So for this next little part, we're going to dive a little bit more into those so we can get a full understanding of each piece. So the nose. So the nose is our environmental control agent. It's responsible for filtering that air. As we breathe it in, it will collect the dust, the allergens, collect the bacteria, those teeny tiny hairs. That's what they're there for. It's also responsible when we're breathing in to heat that air to our body temperature. So our core body temperature is 37 degrees Celsius. If we breathe in air that's colder than that, that's an airway irritant to our lungs, and our airways tend to kind of fight it. So it's the nose is really responsible for helping heating that air up so that there's less irritation going deep down into our lungs. It also is responsible for humidifying that air we breathe. And it humidifies it to about 98% for humidity. So some areas, like majority of you guys responded that you live in the interior, we live in a very dry environment. So the nose does a really good job at humidifying that air we breathe in, because dry air, again, can be a big irritant to our airways. So a big tip is that to try to breathe in through your nose and out through your mouth. When we breathe in through our mouth, we don't have those same environmental control agents. We don't have the filters. It's not as good at heating the air, and it definitely is not as good at humidifying the air that we breathe in. However, understanding that there are going to be some limitations if you have nasal congestion, or if you're just tend to be more of a mouth breather. So this will block the benefits that the nose provides.
Good. So as Alexa said, the nose is super important, and the mouth has a role to play as well. The mouth is really important when we are trying to blow out our breath. Like Alexa said, breathing in through the nose and out through the mouth is an optimal way to really take the benefit of your nose heating, humidifying, and filtering, and blowing it out through your mouth. Now, there is a technique that we teach a lot of our patients and a lot of our clients that's called pursed lip breathing. And we can practice it in the Q&A when our camera is back on. But if you are feeling short of breath, it can help you actually exhale more air. And if you can imagine in your mind holding a feather in your palm of your hand and taking a breath in through your nose, 1, 2, 3, and then blowing it out through your lips that are pursed and tightened, and trying to lift that feather up for as long as you can. So a slow, smooth exhale through your mouth. So it is really important that the mouth is also utilized in breathing, essentially. After the mouth, we're going to kind of skirt past the lungs and jump into the diaphragm. We want to talk about the muscles that we use during breathing, because in the COPD and the asthma population, these muscles are going to work a bit differently. So the diaphragm, which is that lovely orange muscle that's below the lungs, this is our main muscle of respiration. It does about 80% of the work of breathing. And because it does so much of the work of breathing, it is really energy efficient. It doesn't take a lot of energy to actually work for every breath throughout our entire life. It's located below the lungs, and it actually separates our thorax from our abdomen. So it separates all our abdominal organs from our lungs and our heart and everything that's in our chest. But it's not one muscle, it's actually 2 little small hemidiaphragms is what we call them, and they connect at the center. So they work in unison to help us really breathe effectively.
Good. All right. Oh, we skipped past. Nope, we didn't. Oh, great, sorry. Other muscles that are part of our respiratory system are the intercostals and the accessory muscles. So the intercostals are the muscles that are found between the ribs. These muscles are responsible for lifting those ribs up and out and sucking that air into the lungs. The accessory muscles, which are more found up around the neck, these are more inefficient muscles, and they require a lot more oxygen to work. We typically don't use these on our day-to-day breathing. They're more used when we're in a more of an exacerbation state. So they require a lot of work of breathing. And they, again, like I mentioned, they use a lot of oxygen to work. So other airway muscles that are within our airways are known as our smooth muscles. So these are found around the walls of the airways. They're little bands, and these are designed to constrict when irritants are inhaled into our airways. So like I mentioned before, the nose is really good at filtering out that air and humidifying. If those types of particles, reach down into our lungs, airway irritants, then these smooth muscles, what their responsibility is to constrict, to prevent that from getting further into the lungs. So as you can see on the left side, we have a normal airway, and on the other side, we have those bands that are constricted. So as we breathe in some irritants, they can constrict and kind of prevent that air from going deeper down into the lungs.
Good. So the inside of those airways, Alexa talked about those muscles being on the outside. The inside of our airways is made up of really special cells. And so it's a very delicate membrane. I almost tell clients of mine that think about your airways being like wet toilet paper. They're very delicate. So when we cough, it can cause a little bit of irritation, but coughing is what we need to do to clear stuff out. The other way that we clear stuff out are these ciliated cells and these mucus cells. So you can see in the image on the left-hand side, we've got those little yellow cells that look like they have little fibers hanging off of them. We've got these little hairs in our airways that when they work appropriately, they beat back and forth in a really nice rhythm. And they work together to pull dirt or dust or any of those irritants that Alexa mentioned that are caught in the mucus that keeps our airways nice and wet. They help move it up and out. So it's normal to kind of clear your throat throughout the day. We make a lot of mucus. This is normal. And we just don't even think about it. It just comes up, we kind of cough or clear our throat, and then we swallow it down. So these mucus glands and these cilia are extremely important to keep our airways clean by catching and moving the dirt out. When we talk about the lungs, each lung, the left lung and the right lung, are a little bit different. So we have our right lung. It actually has 3 lobes, so 3 distinct areas. We call those the right upper lobe, we got the right middle lobe, and the right lower lobe. And then on the left-hand side, we only have 2 lobes, the left upper lobe and the left lower lobe. Inside of the lungs, we've got these wonderful airways that Alexa will talk about in a second. But the important thing about the lungs is that they do the lion's share of the work to help keep us breathing effectively. And a fun little fact about the air that we breathe in, most of the air we breathe in is nitrogen. It's a gas, it doesn't hurt us, we breathe it in and we exhale it back out. Only 21% of the air that we breathe in is actually oxygen. There's some other gases in there, but oxygen is the one that we really care about.
Mhm. All right, so let's kind of take a step back and talk about the airways. So as we breathe in, whether it be through our nose or our mouth, air travels down through our trachea, also known as windpipe. This is the largest part of our airway, and it is about the size of a garden hose. Then we start seeing it branch. So then it branches into 2 distinct bronchi, each leading into one into the left lung and one into the right lung. These are about the size of a straw. Your airways continue to branch, and they branch around 23 times until they reach the smallest part of your airways. And when they get to this part and they branch and branch and branch, they're about the size of a thread. So as you can see, our lungs are made up of tiny, tiny, or from one big one to tiny, tiny little airways. At the very end of those little threads, we have little sacs, and these sacs are called the alveoli. So they're, as you can see in the picture, they look like little grape-like sacs. We have around 300 million of these alveoli. If you were to take all of these and stretch them out, their surface area would reach around the size of a tennis field, which is pretty amazing to think about, that we have that much surface area trapped inside of our lungs. Now, each one of these little balloon-like sacs, when you look at the alveoli, are teeny tiny thin, and they're so thin that they're about the size of when a soap bubble is about to burst. And there's a reason why that they're so thin, and we're going to talk about that a little bit later on in the presentation.
So now that we've talked about the structure of our lungs and our respiratory system, let's talk about the actual function of it. And there's 2 functions. The first function is what we term ventilation. And that is the process of breathing fresh air in that carries oxygen, and then exhaling out that stale, used up air that actually is carrying carbon dioxide out. And that is a waste gas from the normal processes in our body. So that's normal ventilation. How much air do you think we breathe in a day? Anybody have a guess? If we put it in liters, and you can just pop on, shout out a number, whatever you think. Come on, Doreen, I know you're going to say something.
3 liters.
3 liters. That's a good guess. Any other guesses?
8,000.
Oh, I like where you're going with that. The actual answer is around 11,000 liters of air that we breathe in and out each day. So we're kind of air piggies. We take in a lot of air.
Good. Okay, so just kind of playing off what Lindsay mentioned, taking in a lot of air. So let's talk a little about breathing in and breathing out. So inhalation. So breathing in. So like we mentioned before, the diaphragm, that's that big muscle that's below the lungs. That's the major muscle that we use for breathing in and breathing out, the major muscle of respiration. This diaphragm, when it contracts, so it pulls down, it then brings air into the lungs, almost like a vacuum. It sucks air into the lungs, and the ribs will lift up and out, and now air will enter in. So we get that nice big contraction of the diaphragm down, air enters the lungs. That's inhalation. Exhalation is passive. So that's when this diaphragm relaxes and it returns to that normal position. So it moves up. As you can see in that picture, the diaphragm is now moving up into the chest wall and air is pushed out of the lungs.
So that's ventilation. That's one of the two functions that the respiratory system does. The other one is respiration. Now, respiration occurs at the level of the alveoli. So those little grapes, those little sacs that are right at the end of the thread-sized airway is where air exchange is going to happen, or gas exchange. So surrounding these little grapes is a network of capillaries, and it carries blood flowing through the heart. Every single one of these 300 million alveoli have their own dedicated blood system or blood flow. The oxygen that we breathe in our inhalation with the diaphragm dropping down and we're sucking the air in, it's going to cross that really thin membrane. And Alexa said it's like this thickness of a soap bubble that's just about to burst. So it's as thin as it can be. Oxygen is going to cross from the alveoli across that thin membrane into those capillaries. So then our red blood cells can carry that oxygen throughout our body for our body to use. At the same time that this happens, carbon dioxide, which is that waste from our body's processes, moves from the blood out into the alveoli. So then we can exhale it out when our diaphragm relaxes.
Awesome. So we've talked a little about the anatomy and physiology of the lungs, getting a good understanding. Now we're going to take that and kind of apply it to understanding COPD and asthma. So let's talk a little bit about COPD and what it is. So we always call it COPD, but let's break it down into what it actually means. So C standing for chronic, meaning that it won't go away, but it can be managed. Obstructive, meaning that the airways are narrow and they're floppy. They close early. When we breathe out, that's why we're getting that air trapping, because the exhaled air can't get out because the lungs are going to be floppy and close early. And now this can result in shortness of breath. Pulmonary, meaning that it's affecting the lungs and both sides of the lungs, the right and the left side, not just on one side. And disease, meaning the word disease, meaning that there can be a range of scale from mild, moderate, severe, very severe. So let's talk a little about some of the causes. What can cause COPD? What?
I just noticed an error, but we'll fix it later.
Causes of COPD. So 80 to 90% of COPD diagnosis is caused from a smoking history. The biggest risk factor, and that's what you're is smoking. So quitting smoking is the single most effective way to slow the progression of COPD. But not all COPD is caused from smoking. There are other risk factors. So 10 to 20% of other diagnosed COPD cases are caused by other factors, such as genetic factors. So alpha-1 antitrypsin deficiency. This is a deficiency in a gene, which can cause destruction of the alveoli. Environmental exposure, so being exposed to pollution and secondhand smoke for a chronic period of time. Childhood viral infections that are chronic, that occur repetitively. Occupational exposures to fumes, harsh chemicals, fine particle dust breathed in over time. And then what sometimes there can be some confusion is untreated asthma. So asthma that is chronic, that is constantly have lots of inflammation within the airways, this can then lead to an obstructive process. So these are some of the factors that can lead to COPD. And I think some of the big questions that get brought forward is not every single case is because they have a smoking history. So just know there are other factors that can lead to COPD too.
As Alexa mentioned, though, as smoking can account for 80 to 90% of the causes for developing COPD. And so we wanted to really highlight some of the important information about the impact of tobacco smoke. Earlier in the presentation, we talked about those cilia, those lovely little hairs that are going to move and beat back and forth to move mucus and everything out. When you take one breath in of tobacco smoke, those little hairs, they get paralyzed. And if you continue smoking over years and years and years, there can be greater dysfunction to them and potentially loss of some of those cilia from the airways. After you take your last breath in of tobacco smoke, it takes upwards of about 24 to 48 hours for them to start working again. So that paralysis gets taken away. When they're paralyzed, you have an impaired clearance of mucus, which results in the normal mucus that I mentioned staying in the lungs. And that mucus is warm because the lungs are warm. And it's wet and it's dark, and it's a phenomenal place for little bacteria or an infection to take root and cause a lung infection for you. Infection then can cause persistent inflammation. And as Alexa said in the last slide, asthma that's not treated can potentially develop into COPD because of that persistent inflammation. That persistent inflammation can cause the release of enzymes, and these enzymes can start breaking down that nice elasticity of our lungs and our airways. It's like a stretchy pair of jeans. I know I have a ton of them that you put in the dryer too many times and then they get floppy and they don't stay up. That's the same kind of idea with the airways. It can also lead to potential destruction of the alveoli. So those walls of each individual grate start to break down. And so instead of having each alveoli do what they're supposed to do, you have one kind of blob, if you will, that isn't as efficient. And so this impact of tobacco smoke is irreversible, but by quitting smoking, you can prevent any further damage. So there are different types of COPD. It is important to recognize that not everybody has the same diagnosis. It's a broad term. So under the category of COPD, you have chronic bronchitis, you can have emphysema, you can have something called bronchiectasis, and then we'll discuss kind of where asthma lays in the whole process with everything.
All right, so we'll talk a little bit about chronic bronchitis. So this is one condition of COPD, and it develops over time. Which occurs in the bronchi. And these are those tiny little breathing passages, as you can see in the picture, the little bubble down below. They become inflamed and scarred. All this swelling and inflammation in the airways decreases the size of the airway. So now you don't have that same nice passageway for air to flow through. Because of this, some of the symptoms that comes along with this is coughing, increased mucus production. We can't get that mucus out. Frequent throat clearing and infections. Again, anytime that there's frequent and increase in mucus production, it's a breeding ground for bacteria. So we can see that increase in infection. And like most symptoms of COPD, it can result in shortness of breath. So here's just a quick picture, quick cross section. On the left, you see a normal airway of a bronchi, and then on the right, you see a bronchi that's inflamed and filled with lots of mucus. So as you can imagine, breathing through the left, you're able to get quite a bit more air through versus breathing through the right.
The second type of COPD is emphysema, which I think a lot of people have heard more commonly over the years. And so, like I mentioned before, this is where over time, those individual little walls between the alveoli, or those air sacs, which is in the left of the image, they can start breaking down and getting degraded. So then we end up with what's on the right, where you just have one large sac that's not as effective as in transferring oxygen to the blood and getting that carbon dioxide out of the blood. It also can cause the airways to lose their elasticity, which is important for us when we're done exhaling to keep those airways nice and open so that they don't flop shut. And as you can see, the symptoms are quite similar to chronic bronchitis. We're going to cough, we'll have shortness of breath, we'll have limited exercise tolerance and potential weight loss as well. And in the next image here, you can see it's just a bigger image of what can happen, where you've got structural changes. On the left, you can see that we just have kind of that blob, if you will, and the airways are compressed because they're floppy. So they don't stay open while you exhale and you trap air in, versus on the other side where it's a nice healthy airway.
All right, so another form of COPD is known as bronchiectasis. This is when the airways become stretched and they can form these pockets which collect mucus in them. Usually patients can cough up anywhere from around a cup to a cup and a half of mucus per day. So patients that have bronchiectasis, they're typically always working with physiotherapists, and they really work to help use different devices to get this mucus out. We will talk about this in future presentations down the road about different devices that are out there. But as you can see from the picture on the right-hand side, that it's the pockets that are formed and then mucus just collects in there. Again, this is going to result in patients having increased chance of infection because mucus is, when it's not moved in and out, it's a breeding ground for bacteria. And then lastly, like mentioned before, asthma can, result over time into COPD. So like COPD, it is an airway disease, and it does make it harder for air to get in and out of the lungs. Airways are, though, considered to be what we say more reactive to certain symptoms, such as smoke, dust, pollution, allergens, exercise, or any of those types of triggers. And when I say reactive, I mean those smooth muscles that we talked about at the beginning of the beginning of this session. They tend to tighten when they're exposed to these irritants. And when airways muscles tighten, this now is going to decrease the size of the airway, making it harder to breathe. Now you're breathing through a smaller windpipe. Symptoms of asthma, though, tend to be more wheezing, coughing, again, mucus, that chest tightness, trapping air in, and shortness of breath. As we mentioned, though, it can fall under the COPD kind of umbrella when left untreated. So here, another quick kind of cross section of a normal airway and then asthma symptoms when they are not managed. And again, future presentations, we're going to talk about how to properly manage this so that you don't have, that chronic inflammation and swelling of the airway, so that we can have that nice, normal, healthy airway. So now comparing asthma and COPD, a lot of it overlaps, but there are some distinct differences. So for asthma, we tend to see symptoms early on in life, often in childhood. But, and the other thing is the symptoms tend to be different day to day. Some days you may have shortness of breath, depending on what those triggers are, what you're exposed to. And then the symptoms tend to be more present at nighttime and early morning. They tend to be more aligned with allergies, allergic rhinitis, and eczema. So typically those are kind of, we call like a little triangle where they all present together. And we tend to see a family history of asthma. When treated and, well maintained, asthma can be controlled and we can reverse that airflow obstruction. But if left untreated and all that chronic inflammation is left to kind of brew, then that's where we can kind of switch over to COPD.
So like Alexa said, asthma, it's going to start earlier in life because it's more so something that you're born with. With COPD, the onset is usually midlife, especially if there's a smoking history associated. So you won't develop it until later in life. Symptoms are slower to progress. They tend to be the same. They don't vary day to day. However, some patients may mention that they note that they're coughing and clearing their throat more so in the morning after a night of rest where they're laying down and not deep breathing. So they take that nice big breath in, they tickle their lungs, and they go, oh, time to cough. It is associated commonly about 80 to 90% with a longer smoking history. There will be dyspnea, and what dyspnea is just difficulty breathing or shortness of breath during exercise. And then because if it is just a true COPD, there's no reversibility, which means that that airflow limitation, the floppy airways, we won't be able to give a medication to reverse it, but we can teach you tips and tricks to really manage those symptoms and resume your daily activities of life.
So sometimes people get told that they have an overlap. You have COPD with an asthma component. And we're going to talk a little bit more about this in future presentations, but it's important to note that this can happen. And that's why it's you can be on different medications, aim at addressing both either just your COPD, your asthma, or kind of both of them. So it's just important to note that you may have kind of that presence of COPD and asthma, so that uncontrolled inflammation in the airways. And again, we're going to talk about this kind of going forward. And then lastly, we'll talk a little bit quickly about, summarize the signs and symptoms. We've talked a little bit about that, but mostly for COPD and asthma, there's going to be a cough, whether that be productive, meaning that you're coughing up phlegm, or non-productive, meaning that you're just coughing and it's a dry cough, an irritating cough. Phlegm and mucus production. So again, this could be constant or absent. Almost in all the cases, someone with COPD or asthma will complain of shortness of breath, whether that be at rest or on exertion. And with COPD, we tend to see it progressive. So it develops slowly and worsens over time if we don't get them, your triggers under control or manage you with your proper medication. And like we mentioned at the beginning, it is permanent. We can't reverse it, we can't get rid of it, but we can prevent it from getting worse. And that's what all these series we're going to talk a lot about, is knowing your triggers, preventing flare-ups, and really keeping on top of using your medications appropriately so that we can prevent your symptoms from getting worse and preventing your COPD from progressing.
So there's signs and symptoms. These are the physical ones. So we'll start to note that our physique changes. When we have COPD and we have those floppy airways, we do something called air trapping. So we don't exhale all that air out that we would like to. And so that trapping of the air in, what it does is it actually starts pushing down on that nice diaphragm. So in the image on the left-hand side, you can see the diaphragm is nice and rounded. And on the right-hand side, it's a little bit flatter. When we push on that muscle and we change the shape of it, it's not going to work as much. So then that leads to the second point where we will use those accessory muscles and those intercostals Alexa spoke of to help with the work of breathing, that low flat diaphragm. And then because there is air that's kind of hanging out after you're done exhaling, we didn't get it all out, you'll have what we call diminished breath sounds, which essentially just means that there's a little bit less room for air to flow in and out. But we're going to teach you tips and tricks to get that air out so that we can get more fresh air in. This is just an x-ray we wanted to include. We love x-rays. We're respiratory therapists. Any image is fun to us. But you can see this is just an x-ray representation. On the right-hand side, you've got that white kind of rounded structure at the bottom. You've got the spine through the center. That's a nice rounded diaphragm. On the left-hand side, you can see it's not as nice and rounded. That's a diaphragm that is flattened from air trapping. So in summary, important takeaways, the respiratory system is really complex. There's a lot of tips and tricks and parts to it. So that's why we provided a lot of information today. The damage, unfortunately, is irreversible, but the key thing is that this series of webinars are going to give you those tips and tricks and that knowledge so you can take your lung condition, your breathing condition in control and actually prevent further damage and get back to what you want to do. And like I said, I basically said all that. That's point number 3. But we are going to work on helping lifestyle changes and have guest speakers in so we get you the best medications and connect you with who you need to be connected with so that we can give you the best life you can get. And we want to say thank you so much, everybody. This is our first one. It's all done. Clap, clap, clap. We'll take questions.
Okay.
As soon as we can stop sharing our screen, our mouse seems to disappear. There it is.